What's up? Long time no see. I am back with another video. Welcome to my channel. My name is Shira. Can we just do like a slight dance just because I'm back? Okay. See the new hair? You see it? You see it. You see it. Okay, let's get into it, you guys. So I'm here to talk about internal medicine core as well as internal medicine sub-I, because I'm currently doing an OA rotation in internal medicine sub-I, and the internal medicine core is very similar to the internal medicine sub-I, except for your responsibilities changes. So I'm actually going to be making two videos today. I'll be doing part 1 internal medicine core and then internal medicine sub-I part 2. So make sure you hit that like, subscribe, comment button so you can stay, and hit the bell notification so you know when I upload. Okay, so let's talk about internal medicine core. So that was actually that was about a year ago, and so Ross requires 12 weeks internal medicine core. So I did about 8 weeks inpatient and 4 weeks outpatient. So my first 4 weeks was I was on the floors. My second 4 weeks I was outpatient, and my last 4 weeks I was doing pulmonary and critical care. So during my first 4 weeks, during the first four weeks, I was with Team A with Atlanta Medical Center, which I still talk to. I love them. Like, all of us really connected, the students as well as the residents. We had a really good time. So we were really close. It was a really good rotation. And like I said previously, anytime you come into a rotation, you want to give 150%, especially with internal medicine, because internal medicine is extremely broad. So it covers basically everything for adults. So GI, nephro, neuro, renal, pulm, everything. It's literally step 2 CK. It's like 70% of step 2 CK. So if you don't pay attention, you need to pay attention to this rotation, because it's going to get you through a lot of step 2 CK. So like I was saying before, I have about 12 weeks in my internal medicine core rotation. 4 weeks, first 4 weeks were on the floors, meaning that, in the hospital, you get a patient, you come in through the ED, and the ED says, oh, we can't really necessarily discharge them. We're going to send them up and we're going to admit the patient overnight. That was me. So I would get patients from the ED, work them up along with the residents and the attendings, and then have them on the floors, and then watch their progress, get any consults, whether it was GI, nephro, pulmonology, work with them as well as the case managers to find the best assessment, management, and plan for each patient. So that was a lot of fun. I really learned a lot on the floors. I mean, because there is so much pathology that I got to see. Like, I tell you, there's so much a difference when you can actually see something and see the patient versus just reading it in the book. So it really makes a difference, and it really helps you with step 2 CK. So that's basically what I did during the first 4 weeks, and during that time we were Q4, meaning that on every 4 days we were on call. On the other days, I would come in about 6 o'clock or 6:30 in the morning, and I would round on my patients before we had morning report at 7:30 a.m. So I like to pre-round on my patients, and I also like to talk to the nurse prior to them switching off. So they would switch off night nurse to the day nurse around 7 a.m. So I would like to get there like between 6 a.m. to 6:30 at the latest, just so I can pre-round, speak with the nurses. Hey, what happened overnight? Was there anything that happened overnight? How did they sleep? Did they require any pain medicine? Did they receive any metoprolol? Was their heart rate okay? Did they have any bowel movements? If they're constipated, did they take all of their medicines as they should? Like, did you have to call the security? Like, your nurses are your friends. Get to know your nurses, because they're going to be with your patients majority of the time, and they can give you the most valuable information, and they know exactly what to look for. So I had a really good relationship with the nurses. And basically how you do that is, just be respectful, introduce yourself, ask them if they have time to talk to you, and if they do, can I ask you a couple questions. That's basically how you do that and how you build relationship with nurses. And if they need something, you always check with them during the day, like, hey, is there anything you want me to tell the team about the patient, or any of concerns about the patient you want to tell them as well. So it's a two-way street. You can't just be like, hey, give me something, give me, and they don't get anything. So you also want to allow them, if they have any questions, to ask you, so you can tell your team as well as you're attending to see if there's anything that you could do on our side. So it's a two-way street. So that's what I did from basically 6 a.m. to 7 a.m. 7 a.m. was morning report. So during morning report is you have all the attendings. It was about 4. You had to have at least one attending there, but all the attendings came when we were at when I was at Atlanta Medical Center. And basically we have the team who was overnight give you basically like little tidbits of the patient. Like, this patient is a 23-year-old female with significant past medical history of cocaine abuse, that's coming in with chest pain associated with diaphoresis and nausea, and one episode of emesis, non-bloody emesis, and her EKG showed ischemia. What do you think? So you're sitting in a room and you say, like, what are your differentials? What will you be looking for in physical exam? What would you like to order? So it's like, to me, it was almost like a game. So I really enjoyed it. And I also really like to hear about other people's thinking processes, especially from the other residents as well as the attendings, because they've done it longer. So again, if you want to learn something, go read on your own, but also you want to get in that person's head to figure out why they said it. So I really enjoyed that part. And then after we went through that, that took about maybe 30 minutes. After that, I finished whatever I need to do, like writing notes. And then we also pre-rounded with the residents before the attending came there, just to make sure that everybody was on the same page. So we did that from about 7 to about 9 a.m. And then the attending would come and then we would do rounds. Based on the attending, they would do walking rounds, meaning that you would go talk about each patient. It would be about 5, 6 of us outside of the door. Like, this patient has this. This is the assessment and plan. This is what happened overnight. That's walking rounds. Or we'll have sit table rounds where we're sitting in a room just with the residents and attending, and we talk about all the patients all at one time. And then we go see the patients, or the attending will decide, like, hey, I just want to see the new patients with you, and I'll just go with the senior. And then that was it. That was based off attending, but all of my attendings did walking rounds except for one. He did a mixture of table rounds as well as walking rounds. I actually prefer walking rounds because it keeps me, I'm more visual. So if I'm in front of the room and I'm talking about a patient and we're talking about the assessment plan, and then we go in there and do the physical exams together and we talk about it, and then we come out and I write down whatever that needs to be done, it just makes it easier for me. But to each his own. I'm not the boss. I'm not running the show. So whatever the attending wants to do, hey, you got it. You know what I'm saying? So that's basically what we did from that. And we would do rounds for basically from 9 a.m. to about maybe 11 a.m., 12 p.m., depending on how many patients that we had. So the team was composed of 1 to 2 students, 2 interns, and at least 1 senior resident and 1 attending. So we would have about maybe 10 to 15 patients. And as a third year, you were able to take up to 2 patients, and as a sub-I, you were able to take up to 4 patients. So in my third year, I took up to 2 patients. So that's what I did from basically 6 a.m. to 12. I ate lunch. And then I made sure all the notes and everything was done so they could do some addendum or whatever they needed to do with the attending and order or make sure that the residents had all the labs in for the morning, because depending on where you rotate, sometimes you can put orders in, but those orders will always have to be co-signed, or sometimes the student will not be able to put in orders depending on what rotation and what hospital facility you have. At AMC, I believe we could do co-sign orders, but majority of the time the residents or the attending would put in the orders, but you could do your notes and everything like that. So that's completely fine. So I did that from about 8, and then made sure whatever the residents needed or any labs that need to be done from basically 12 to, I would say, 1 or 2 o'clock. And then around 2 or 3 o'clock, check back with the caseworkers or the nurses to see if anything else was going on, or if they had any additional questions about the patient or any concerns about the patient. And around that time, the day would start slowing down, and then basically we would sign out, and then that was it. So I was there from about maybe 6 a.m. to about 3 p.m., 4 p.m. But we were on call Q4, meaning that we're on call every 4 days. So we had to stay overnight. We would come in, check in on the patients, then leave, and then come at night to get any patients that were coming in through the ED at night, and then sign them out around 6 a.m., give it to the team that was up there for the morning, and then go home. Let's just say after I finished, whether it was Q4 or it was 6 a.m. to 4 p.m., if it was 6 a.m. to 4 p.m., I would go to Starbucks, and if it was Q4, I would take a shower, take a nap, wake up around like 1 o'clock, and then go to Starbucks. So, I love Starbucks, and I would stay there until they close at about 10 o'clock. So you ask me, Sherry, you told me all of this information, but how did you study for IM? Are you ready? 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 Step up to medicine. So I use Step Up to Medicine, but I also mainly use Uworld because IM has about, I would say, over 1,000 questions. So yeah, and that took a lot of time because that was so just to back up a little bit, I guess what I used Step Up to Medicine, and I use this, and I really like Step Up to Medicine. It's pretty so for example, I'll just go to the beginning. So they actually do this book by system. So as you can kind of see, you see cardiovascular system, diseases of the pulmonary system, disease of gastrointestinal system, and they do basically diagnosis, physical exam, management, and treatment, and what you're going to order and what to look for. So I really like the way that it was organized. I didn't finish reading Step Up to Medicine just because I was in the hospital a lot. And I was really wanting to finish all the Uworld questions, because reading is one thing, but being able to apply it was different. So I mainly did the questions. Like if I got a question on pericarditis, regardless if I got it right or wrong, I would flip to pericarditis, read all the explanation, and then read in the thing for pericarditis what all the general characteristics of diagnosis and treatment for pericarditis. That's the way I studied for it, and I just repeated it over and over again because it was literally like over 1,000 questions on Uworld. I didn't use case files. I'm not really big fan of the case files. I really didn't do that. I mainly use Uworld and Step Up to Medicine, and I used a little bit of Sketchy. That's when they had just came out with Sketchy IM. I didn't fully finish that Sketchy IM, but I'm actually using it to study for Step 3 and review stuff from Step 2 CK. So that's basically what I did to study for my internal medicine shelf, and some of the things that I did overall, internal medicine is extremely broad. You really have to know how to really assess a patient when you're interviewing a patient, because like for me, I really wanted to get everything I could. So I would ask the residents like, hey, can I take this patient? I would do the interview, well, the resident would still be in there, but I would be the interviewer. I would do all the questions as well as the physical exam, and then I would write up the notes, and then I would present that patient to the residents as well as the attending and follow up on that patient. So my whole goal was to act as an intern, even at a third year level, because I really wanted to make sure I'm getting the best out of the rotation. And that goes for any rotation. You want to give 150%. You are paying thousands of dollars to be here. So you got people to help you and to understand how these things work as far as diagnosis, management, and treatment. Because in a little while, in 2 years or 2 months, or in my case, 54 days, you're going to be an MD and you're going to be the one that's calling the shots, regardless of what rotation you're in. So you need to get used to having that kind of responsibility. So I hope that you enjoyed this video. I, of course, will be having part 2 for internal medicine sub-I, and I hope to see you again. See you later.